my slide. So most of the lecture is taken from shorts and some from guidelines such as NCCN and others from journal articles. I'll first be discussing the pancreas. These are the topics included in this morning's lecture. So we'll be going through briefly on the anatomy, histology, then acute and chronic pancreatitis, pancreatic cystic neoplasms, pancreatic neuroendocrine tumors, and pancreatic ductal adenocarcinoma. So it's quite a lengthy topic. So first we go with the basic topics. The pancreas is divided into the following regions: the head, the onset, the neck, the body, and the tail. And for the embryology, it is formed by the fusion of the ventral bud and the dorsal bud. So sometimes it's asked in the exam, so you just have to memorize it. The ventral bud eventually forms the inferior portion of the pancreatic head and the onset process, and also forms the main pancreatic duct of Wirsong, while the dorsal bud forms the superior portion of the pancreatic head, the body and tail of the pancreas, and also the accessory pancreatic duct of Santorini. So the pancreatic duct usually has a higher pressure than that of the CBD. This is to prevent the reflux of the bile, and it joins the CBD and empties into the ampulla of bladder. So there are variations in the pancreatic duct and with regards to its how it joins with the CBD. So this occurs with equal variance. It can form a true common channel, or it can merge at the end of the papilla, or it can remain distinct to the end of the papilla. With regards to the persistence of the duct of Santorini, in 60% this persists as the lesser pancreatic duct and drains to the lesser papilla. The lesser papilla is located 2 cm proximal to the ampulla of bladder. Well, the ampulla of bladder, as we know, is at the D2 and is located at the medial aspect. In 30%, the duct of Santorini ends as a blind accessory duct. And in 10%, the duct of Wirsong and Santorini fail to fuse, and this is called the pancreas divisum. So in pancreas divisum, the bulk of the pancreas, meaning the body and tail, is being drained by the duct of Santorini, which predisposes the patient to episodes of pancreatitis. For the arterial supply of the pancreas, for the head, it is mostly supplied by the GDA and SMA, and for the body and tail, supplied by the splenic artery. Just things to note, for the GDA, test clamping is done prior to division and ligation. This is part of the procedure of the Whipple's procedure. And another thing to note during the Whipple's procedure, you have to watch out for the presence of the replaced or accessory right hepatic artery from the SMA. Then for the venous drainage of the pancreas, this drains the posterior superior pancreatico-duodenal vein drains into the portal vein, while the anterior superior pancreatico-duodenal vein drains into the SNV. They drain the head of the pancreas, while the body and tail is drained by the splenic vein. So, something to note is during the Whipple's procedure, we do tunneling behind the neck of the pancreas, since there are no branches at the anterior aspect of the SNV. Then at the side, these are just variations of how the inferior mesenteric vein joins either the splenic vein or the SMV, or the junction of the splenic vein and SMV. Since this was mentioned in Schwartz, I also included it in my slides. So the most common variation is the draining of the IMV into the splenic vein, which occurs in 34 to 71.7%. For the lymph node drainage of the pancreas, You just have to memorize the lymph node stations. So regional lymph nodes of the pancreas include stations 5 to 14 and 17 and 18. The rest of the lymph node stations are considered distant metastatic sites. Now we go to the histology. The exocrine pancreas accounts for 85% of the gland, while endocrine accounts for 2%. And to prevent pancreatic insufficiency, you would need at least 20% of normal pancreas. We can just skip through these. You can just read this in Schwartz. Here, sometimes they ask this in the exam regarding the genetic mutations. So if you have a genetic mutations of the serine protease inhibitor gazelle type 1, there's loss of function of this inhibitor, and this can lead to hereditary pancreatitis. Then if you have a mutation in the PRSS1 gene, this causes premature activation of trypsinogen, which also leads to hereditary pancreatitis. For this, better to memorize it. So for the islet cells, for alpha cells, they produce glucagon, beta cells produce insulin, delta cells produce somatostatin, epsilon cells produce ghrelin, and the PP or F cell produces pancreatic polypeptide. For the distribution, the beta and delta cells are evenly distributed throughout the pancreas, while the head and uncinate process contains more PP cells. Alpha cells, on the other hand, are located more on the body and tail, which is why glucagenomas are more common in the body and tail. So we now go to acute pancreatitis. For the pathophysiology of acute pancreatitis, there is autodigestion of the gland due to premature activation of the trypsinogen to trypsin. This usually caused in up to 80% by gallstones or alcoholic intake. Other causes are iatrogenic, such as in ERCP, hereditary pancreatitis, tumors, marked hypertriglyceridemia of more than 1,000, and also some medications. As we all know, the characteristic pain in acute pancreatitis is an acute onset, persistent, severe epigastric pain, often radiating to the back. Then some recall questions are the Cullen sign, which is the bruise-like discoloration around the umbilicus, and the Gray Turner sign, which is the bruise-like discoloration in the flanks. So sometimes this is asked in the exam. For the diagnosis of acute pancreatitis, this is based on the revised Atlanta guidelines. We have to have at least 2 of the following: abdominal pain consistent with acute pancreatitis, increased amylase or lipase of at least 3 times greater than the upper limit of normal, or in the third, characteristic findings of acute pancreatitis on imaging. And after diagnosing the patient with acute pancreatitis, it is also important to determine the etiology. For the imaging, we can request for an ultrasound just to determine if the etiology is acute biliary pancreatitis, and also contrast-enhanced CT scan, though this is not routinely done. If you plan to do a contrast-enhanced CT scan, this is usually done at least 72 to 96 hours after the onset of symptoms. This is because if you do the CT scan too early, you might underestimate the extent of the pancreatic or peripancreatic necrosis. Reasons for requesting for a CT scan include the following: if the diagnosis is unclear, if the patient fails to improve clinically within 48 to 72 hours of hospital admission and intravenous hydration. And at the same time, this can also help you detect pseudoaneurysms, active bleeding, and or the presence of hematoma. There are 2 types of pancreatitis based on the revised Atlanta guidelines. These are the interstitial edematous pancreatitis and the necrotizing pancreatitis. So as you can see in the CT scan images, in necrotizing pancreatitis, the parenchyma of the pancreas does not enhance due to the presence of the necrosis. Then next we discuss the local complications in pancreatitis. So there are four local complications. Two occur in less than 4 weeks, while two are present if present for more than 4 weeks. So in interstitial edematous pancreatitis, you can have acute peripancreatic fluid collection and persistence of more than 4 weeks. This can lead to pseudocyst. And in necrotizing pancreatitis, you can have acute necrotic collection, and after 4 weeks, this can lead to walled-off necrosis. Any of these local complications can be sterile or infected, and for infected necrosis, this usually the incidence peaks in the third to fourth week, and you will suspect this if there's deterioration of the patient clinically and or if there's presence of gas within the collection on CT scan. You can confirm the presence of infection via fine needle aspiration, though this is not routinely done. So these are just CT scan images of the local complications. As you can see, there's a homogeneous fluid collection around the pancreas with no definable wall. Then after 4 weeks, the fluid collection, if persistent, can become more well-defined. So this already becomes a pseudocyst. Here we have the acute necrotic collection. So it's more heterogeneous, and there's also no definable wall. After 4 weeks, the wall becomes more defined, and this turns into a walled-off necrosis. In the CT scan image, you can see the presence of gas within the collection. This signifies that this is an infected walled-off necrosis. For grading of the severity of the acute pancreatitis, there are several scoring systems. You don't have to memorize all, but clinically, BISAP, the bedside index for severity of acute pancreatitis, is easier to use. However, for the exam, they usually ask the Ranson's criteria. So you have to memorize the components of the Ranson's criteria, which are age, WBC, blood glucose, LDH, AST, hematocrit fall, BUN elevation, calcium, arterial PO2 base deficit, and fluid sequestration. So based on the Ranson's criteria, if you have a score of 0 to 2, there's around 1% mortality, but when you have a 3 or more score, the mortality rate jumps. So at the score of 3 to 4, there's already a 15% mortality. 5 to 6, there's a 40% mortality, and with a score of greater than or equal to 7, there's a 100% mortality. Other classifications for the severity, which is also mentioned in Schwartz, are the revised Atlanta classification and the determinant-based classification. So for the revised Atlanta classification, we determine the severity based on the presence of organ failure, whether transient or persistent, and the presence of local or systemic complications. So for mild, there's no organ failure and no local complications. With the presence of transient organ failure, meaning less than 48 hours, or the presence of local complications such as the ones mentioned earlier, walled-off necrosis, pseudocyst, this automatically classifies the patient as a moderately severe pancreatitis. And for the severe classification, this is for patients with persistent organ failure. So they use the revised Atlanta classification uses the modified Marshall scoring to assess the organ failure, and they assess the following organs: the lungs, the kidneys, and the cardiovascular. For the determinant-based classification, it is somewhat similar. For mild, there is no organ failure and no peripancreatic necrosis. For moderate, there's transient organ failure or sterile pancreatic necrosis. The presence of an infected necrosis automatically classifies the patient as either severe or critical. If the patient has either only one, either persistent organ failure or infected pancreatic necrosis, that's severe. But if the patient has both persistent organ failure, meaning more than 48 hours, and infected peripancreatic necrosis, then that classifies the patient as critical. So we'll just breeze through these. Of course, for acute pancreatitis, you need pain management and adequate fluid resuscitation. Some guidelines recommend the use of lactated ringer solution for the fluid resuscitation. Then for the nutrition, once normal bulimia is restored, you can already start oral enteral feeding. So you just have to avoid aggressive early enteral feeding if because if this is done before adequate resuscitation, this would put the patient at risk for non-occlusive mesenteric ischemia. If the patient has organ failure, the patient should be admitted at the ICU. Then antibiotics are not given as prophylaxis. As mentioned earlier, ERCP is done only if the patient has cholangitis, since the procedure itself also has risks such as increasing the severity of the pancreatitis, bleeding, perforation, and cholangitis. With regards to cholecystectomy for biliary pancreatitis, this can be done on the same admission if the patient has mild pancreatitis, meaning the patient has no local complications and no organ failure. If the patient has peripancreatic collections, it is better to wait for these peripancreatic collections to resolve or to wait more than 6 weeks before performing the cholecystectomy. For the management of the local complications, for pseudocysts, we no longer base the indication for intervention on the size and duration of the pseudocyst. So it used to be what was originally thought was if it's more than 6 cm or more than 6 weeks, if the pseudocyst is persistent, then we have to do an intervention. But nowadays, the indication for intervention is if it is symptomatic or enlarging. So the options for pseudocysts are EUS-guided transmural drainage or transpapillary stenting if there's a pancreatic duct communication. Then other options include surgical drainage such as cystogastrostomy, Roux-en-Y cystojejunostomy, which is the most versatile, and cystoduodenostomy. Percutaneous drainage is also an option. However, this is avoided because of the risk of external pancreatic fistula. For wall duct necrosis, these are some of the options: endoscopic, transgastric, or transmural drainage or debridement, and video-assisted retroperitoneal debridement. So for the endoscopic transmural debridement, it is done by the endoscopist. So they use an endoscopic ultrasound to locate the cyst and do a transmural puncture of the stomach and put stents in. Then for the video-assisted retroperitoneal debridement, usually the patient already has a previous pigtail placed into the cavity of the necrosis, and this is used as a guide. So the surgeon will enter the plank with the pigtail as a guide so that you can reach the central area of, meaning the peripancreatic area. So we have here the step-up approach. More or less, the thing to remember here is you have to wait 3 to 4 weeks prior to doing any surgical intervention. So it says here 3 weeks, but better to wait 4 weeks. This is so that the wall of necrosis would already have a mature wall. So if the patient is still septic and it's still less than 3 weeks, then first give antibiotics. Then see if it works. If the patient is still septic and it's still less than 4 weeks, then do drainage such as percutaneous drainage or endoscopic drainage. Then, if the patient is still septic and it is already more than 4 weeks, then you can already do the VARD or the endoscopic debridement or minimally invasive debridement. If this is not enough, then that's when you do a laparotomy. And while waiting for the 4 weeks, some indications of doing a laparotomy within 4 weeks include abdominal compartment syndrome and other acute abdomens, so such as perforated viscous hemorrhage and hemorrhage. We now go to chronic pancreatitis. So these are just some of the theories on how chronic pancreatitis develops. So in the sentinel acute pancreatitis event, there's a critical episode of acute pancreatitis which causes a cascade of events leading to the collagen production and fibrosis. And another is the multiple hit theory, wherein multiple episodes of acute pancreatitis cause progressive inflammation and scarring of the pancreas. So, in acute pancreatitis, there is activation of the pancreatic stellate cells into myofibroblast-like cells, leading to collagen synthesis and fibrosis. Here are the common etiologies for acute pancreatitis. Then here we already mentioned this earlier, so we can just skip these. Also mentioned earlier is the pancreas divisum, which occurs in 10%. So there is a functional obstruction since the duct of Santorini is small compared to the duct of Wirsong. And one option for this is to do stenting, sphincteroplasty and stenting of the minor papilla. So for the pain in chronic pancreatitis, it can be due to ductal hypertension, due to strictures or stones, and this usually manifests as pain exacerbated by eating. But if there is chronic pain without exacerbation, then this is usually due to parenchymal disease or retroperitoneal inflammation with involvement of the nerves. So to relieve the pain, some of the strategies are to decompress the pancreatic duct, to reduce the secretion of the pancreatic duct, and to to resect the area where there is chronic inflammatory change. You can just skip through these. These are just you can just read about these in Schwartz. These are just tests that measure the exocrine function of the pancreas. So for the diagnosis of acute pancreatitis, the most sensitive radiologic test for the diagnosis is ERCP, and Chronic pancreatitis is diagnosed by assessing the main pancreatic duct in the side branches for presence of abnormalities. And other imaging modalities that can be used include EUS, CT scan, and MRI. So this just shows the complications of chronic pancreatitis. So patients with chronic pancreatitis can also have pseudocysts, same as in acute pancreatitis. Then there is also presence of calcifications in the gland, stones in the pancreatic duct, stenosis in the pancreatic duct. There could also be bile duct stenosis and duodenal stenosis due to the presence of a inflammatory mass at the pancreatic head. And another complication is this pancreatic head mass, which is inflammatory, can have a focus of carcinoma in 3.7%. Other complications include pancreatic enteric fistula, splenic and portal vein thrombosis, and as mentioned earlier, carcinoma. Pancreatic ascites is another complication. This can be managed by anti-somatostatin analogs, bowel rest, TPN, complete paracentesis, and for those who fail to respond to medical treatment, surgical therapy is an option, such as Roux-en-Y pancreatic jejunostomy, and if the leak is at the tail, distal pancreatectomy. For the management of chronic pancreatitis, one important thing is that the patient should stop alcohol intake, and this leads to pain reduction or relief in 60 to 75%. Then other medical treatments include neurolytic therapy, pain medications, anti-secretory therapy, and giving of enzyme therapy. For endoscopic therapy, these include pancreatic duct stenting, pancreatic duct sphincterotomy, and endoscopic stone removal. As mentioned earlier, for pancreas divisum, an option is to do minor papilla sphincterotomy and dorsal duct stenting. We now go to surgical therapy for chronic pancreatitis. So one option is to do a transduodenal sphincteroplasty, but this is limited only to patients with focal obstruction and inflammation isolated to that area. We now go to the resectional options. So one option is to do a total pancreatectomy with islet cell autotransplantation. Then if the problem is localized to the body and tail, then distal pancreatectomy is an option. If it's localized at the head, these are the options. You can do a Whipple procedure or a duodenal preserving pancreatic head resection, which includes the following: the Beggar procedure, the Burn modification, the Frey procedure, and the Hamburg modification. So for the Beggar procedure, the neck is divided and a segment of the head of the pancreas is poured out. Then this area is reconstructed with a segment of the bowel. For the Burn modification, it's similar to the Beggar procedure, but the neck is not divided. So for both procedures, this can include CBD drainage as well. For the Frey procedure, the removal of the tissue at the pancreatic head is less extensive, but what's different about the Frey procedure is that it's like a hybrid procedure, since it also There's also a longitudinal dissection of the pancreatic duct, unlike the beggar and the burn. So it's also, in a way, it also drains the pancreatic duct. For the drainage procedures, we have the Duval, the Puesto Gillespie, and the modified Puesto procedure. So usually when the patient needs a drainage procedure, automatically this is the modified Puesto procedure. The Duval and the original Puesto procedure is no longer done. Here is just a summary of the surgical options for chronic pancreatitis. So if the patient has an inflammatory mass at the head without stenosis of the pancreatic duct, then options include the Becker procedure, the burn modification, and the Whipple procedure, especially if there's suspicion of malignancy in the pancreatic head. If the patient only has ductal dilatation of more than 7 millimeters without an inflammatory mass, then it's better to do a modified Puesto procedure. If the patient has both an inflammation at the head and also an obstruction in the pancreatic duct, then better to do a Frey procedure. For patients with small duct disease, options include a V-plasty and total pancreatectomy with islet cell autotransplantation. So that's it for chronic pancreatitis. We now go to pancreatic cystic neoplasms. So these are the common pancreatic cystic neoplasms. We have the serous cystadenoma, the SCN, which is benign. Then for our pre-malignant neoplasms, these are the mucinous cystic neoplasms. We have the MCN, mucinous cystadenoma, and the IPMN, intraductal papillary mucinous neoplasm. Then for the cystic neoplasm with low-grade malignancy, we have the solid pseudopapillary tumor. So to differentiate the pancreatic cystic neoplasms, we can request for imaging and cyst fluid analysis. So you can request for a CT scan, an MRI, or an EUS. The advantage of a CT scan is that you can see the calcification better, but usually we request for an MRI since there's superior soft tissue contrast and there's improved depiction of the ductal anatomy, and also it's more sensitive to in assessing the communication with the main pancreatic duct and also the presence of internal septations in the cyst. If MRI is inadequate, then we also request for an EUS, which can also detect the internal septations and the neural nodularity, and in addition, fine needle aspiration of the fluid can be taken for analysis. So this is a table showing the common pancreatic cystic neoplasms. So for SCN, which is benign, this is microcystic and there's usually a presence of a central scar. For MCN, the patient is usually female and the lesion is macrocystic, and sometimes there's the presence of peripheral calcification. For IPMN, there's a dilatation of the main pancreatic duct for the main duct type, and for the branch duct type, there's a presence of dilated side branches, which are usually multiple. Then for the solid pseudopapillary tumor, the patient is usually a young female, and this is present usually in the body and tail. And the lesion contains solid and cystic components. So for the fluid analysis, as mentioned earlier, the pre-malignant lesions have mucinous fluid, This includes the MCN and the IPMN. And if the fluid is mucinous, this usually correlates with having an increased CEA in the cyst fluid. So for SCN, as as we can derive from the name, the fluid is serous, so the fluid CEA is also low. Then I think some recall questions. Usually in MCN, there's an ovarian-like stroma, and in IPMN, there's a fish eye appearance on on EGD. Then for the pancreatic duct communication, it is IPMN that has pancreatic duct communication, which also correlates with having increased amylase in the cyst fluid. For the management of the cystic neoplasms, for SCN, since it is benign, we only resect if the patient is symptomatic, because sometimes the tumors can be quite large, and this causes compressive symptoms. For MCN, there's some differences in the guidelines. For the European guidelines, they only recommend resection if the lesion is greater than or equal to 4 cm, if the patient is symptomatic, or if there's a high-risk feature, such as the presence of a mural nodule. And they recommend doing an oncologic resection. So since MCN is usually located at the body and tail, this includes a distal pancreatectomy with splenectomy and lymph node dissection. For the Fukuoka guidelines, the difference is that they recommend a resection for all surgically fit patients. So this includes even the lesions less than 4 cm. And if the lesion is less than 4 cm and does not have a mural nodule, then parenchymal sparing resections can be done, such as central pancreatectomy or a distal pancreatectomy with spleen preservation. Here is the algorithm for the revised Fukuoka guidelines. What's present in the Schwartz is actually the original Fukuoka guidelines released in 2012. But this is the revised one, and there's actually a newer one, the Kyoto guidelines released in 2023. So there's just some differences in the algorithm, but the features of the high-risk stigmata and the worrisome features are more or less the same. So for the high-risk stigmata, these are features wherein you would have to do a resection. So this includes obstructive jaundice, enhancing mural nodule of greater than or equal to 5 millimeter or with solid component, main pancreatic duct diameter of at least 10 millimeters, and if FNA was done, presence of suspicious or positive results of cytology. For the worrisome features, in the revised Fukuoka guidelines, they recommend doing an EUS for further evaluation. However, in the Kyoto guidelines, the presence of the worrisome features, you have to, this is the next step in the algorithm. If the patient is young and fit for surgery, then they recommend doing a resection. And also there is repeated episodes of acute pancreatitis, meaning it's the lesion is symptomatic, or if there are multiple worrisome features, then they also recommend resection. So these are the worrisome features, which is almost the same as in the revised Fukuoka guidelines. So these are acute pancreatitis, elevated CA19-9, new onset or acute exacerbation of diabetes, cyst size of greater than or equal to 3 centimeters, enhancing mural nodule of less than 5 millimeters, thickened or enhancing cyst walls, main pancreatic duct of 5 to 10 millimeters, abrupt change in caliber of the pancreatic duct with distal pancreatic atrophy, presence of lymphadenopathy, and cyst growth rate of 2.5 millimeters per year. So, in the absence of the high risk stigmata or worrisome features, what we do is just surveillance. And this is also an option if for patients if there's only one worrisome feature of the pancreatic cyst size of greater than or equal to 3 centimeters. So if the largest cyst is less than 2 centimeters in size, then we do repeat imaging after 6 months, then after and then every 18 months if stable. If it's between 2 to 3 centimeters, then we do repeat imaging after 6 months twice, then every year if stable. If the largest cyst is greater than or equal to 3 centimeters, then we do imaging every 6 months. For the European guidelines for IPMN, it is more or less similar to the Fukuoka and Kyoto guidelines. So for the resection, their absolute indications include positive cytology, solid mass, jaundice, enhancing neural nodule of greater than or equal to 5 millimeters, and main pancreatic duct diameter of greater than or equal to 10 millimeters. Then for the relative indications for resection, these include a growth rate of greater than or equal to 5 millimeters per year. So this is this higher threshold compared to the Kyoto guidelines, which is at 2.5 millimeters per year. Then increased CA19-9 main pancreatic duct dilatation of 5 to 10 millimeters, which is the same as in the Kyoto guidelines. Cyst diameter of greater than or equal to 40 millimeters. So this is a bigger cyst size compared to the 3 cm cutoff of the Kyoto guidelines. New onset diabetes mellitus, acute pancreatitis, and enhancing neural nodule of less than 5 millimeters. So the last three are the same as in the Fukuoka or Kyoto guidelines. So that's it for cystic neoplasms. We now go to pancreatic neuroendocrine tumors. So for pancreatic neuroendocrine tumors, a main prognostic determinant is the tumor grade. So this would depend on the mitotic rate and the Ki67 proliferation index. This would classify the patient as either grade 1, grade 2, or grade 3 neuroendocrine tumor. So there are also non-functional and functional neuroendocrine tumors of the pancreas, and we will be discussing them briefly. So for insulinoma, this is the most common functional PNET, and majority are benign. This usually solitary, and in the exam, usually the case scenario is you will be able to identify the Whipple's triad, which is the patient has symptoms of hypoglycemia with low serum glucose of less than 50 and relief of symptoms with administration of glucose. So based on the NCCN, you do the lab workup for insulinoma, which includes checking the insulin, proinsulin, C-peptide levels, and also request for multiphasic abdominal CT scan or MRI. So for PNETs, the lesion usually appears as hyperintense on the arterial phase, in contrast with the pancreatic adenocarcinoma, which appears hypodense in the pancreatic parenchymal phase. So other imaging studies that can be requested if needed are EUS, then delta T PET, chest CT. Then if you, since the lesions are usually small but symptomatic, sometimes it is still difficult to identify the location of the lesion, even with the multiple imaging modalities. So one option is to do selective arterial calcium stimulation test to localize the lesion. So for resectable insulinoma, depending on the size and the location of the tumor, if it is exophytic and or peripheral in location and not adjacent to the main pancreatic duct, then an option is to do tumor enucleation. But if the tumor is deep and in close proximity to the main pancreatic duct, then you would have to do either a Whipple's procedure or a distal pancreatectomy, depending on the location. So as you can see, there's no mention of doing a lymphadenectomy for insulinoma since it is mostly benign. For the next PNET, we have gastrinoma, which causes Zollinger-Ellison syndrome. This leads to acid hypersecretion and peptic ulceration. The patient can also have symptoms of diarrhea. So the lesion of gastrinoma is located in the gastrinoma triangle or the Passeros triangle in 90% of cases. This is an area defined by the, the following points: the junction of the cystic duct and the common bile duct, the D2 and D3, and the junction of the neck and body of the pancreas. So for the workup for gastrinoma based on NCCN, we check the serum gastrin level, which is greater than 1,000. We do multiphasic abdominal CT or MRI, and also genetic counseling and testing. So we have to rule out the presence of MEN1. One way to do this is to check the serum calcium of the patient. So if for resectable gastrinomas, if it is present in the duodenum, then the surgical option is to do a full thickness excision of the duodenal wall along with periduodenal node dissection. If the location of the lesion is at the head, then an option for lesions that do not involve the main pancreatic duct is to do enucleation and with periduodenal node dissection. But if the lesion is deeper and in close proximity to the main pancreatic duct, then you would have to do a Whipple's procedure. Then for lesions at the distal, at the body and tail of the pancreas, the surgical option is to do a distal pancreatectomy with splenectomy and lymphadenectomy. So as you can see, there's lymph node dissection is already included in gastrinoma. For glucagonoma, the lesion is usually located at the body and tail. And for the test, in the test question, usually the patient presents with dermatitis. This is the necrolytic migratory erythema, and also mild diabetes. So for the workup, we do test the serum glucagon level and also the blood glucose. And for the imaging, we request for a multiphasic abdominal CT or MRI. Then for resectable disease, since this is usually at the body and tail, the surgical management is a distal pancreatectomy with lymphadenectomy and splenectomy. For somatostatinoma, usually in the test question, there's presence of gallstones, diabetes, and steatorrhea. So the treatment of this In the NCCN, there's no separate algorithm, but it's the same as in non-functional PNET. Well, in Schwartz, it was just mentioned to do complete excision of the tumor and cholecystectomy. For VIPoma, this leads to Werner-Morrison syndrome or WDHA syndrome, which stands for watery diarrhea, hypokalemia, and achlorhydria. So the distinguishing feature in this is that there's severe watery diarrhea, and the lesion is usually located at the distal pancreas. So for the workups, we check the electrolytes and the serum VIP levels. Then we request for abdominal CT or MRI. And for resectable disease, for the head we do Whipple's with lymphadenectomy, and for the body and tail we do distal pancreatectomy with lymphadenectomy and splenectomy. So here is a table showing a summary of the functional PNETs. For the clinical manifestation, insulinoma manifests with the Whipple triad and with symptoms of hypoglycemia. For gastrinoma, the patient has peptic ulcer and diarrhea. For VIPoma, the patient has watery diarrhea. For glucagonoma, the patient has necrolytic migratory dermatitis and diabetes. Then for somatostatinoma, the patient has gallstones, diabetes, steatorrhea, and diarrhea. So the symptom of diarrhea is also present in gastrinoma and in somatostatinoma, but in VIPoma, it's really a severe watery diarrhea. So those are the keywords to look for. Then for the location, just have to remember that gastrinoma usually occurs at the Passerose triangle, while glucagonoma usually occurs at the glucagonoma and VIPoma usually occur at the distal pancreas. For the other information from this table, insulinoma is the most common, but this is usually benign. And the functional PNET most associated with MEN1 is the gastrinoma. Hence, you have to rule out MEN1 when you're confronted with a patient with gastrinoma. For the surgical management, as mentioned earlier, routine lymphadenectomy is not required for insulinoma. Then for the rest, more or less, is pancreatic resection with lymphadenectomy. Then for somatostatinoma, since the patient usually has gallstones, there's an added cholecystectomy. For non-functional PNET, we request for a multi-basic abdominal CT or MRI. And as mentioned earlier, the lesion appears as a hyperattenuating in the arterial and venous spaces. So the surgical management depends on the size. For lesions less than or equal to 2 cm, you can do an enucleation with or without regional lymphadenectomy, or formal pancreatectomy with or without regional lymphadenectomy. Usually in less than, and also observation is also an option. For lesions less than 1 cm, usually lymphadenectomy is not needed, but in lesions between 1 to 2 cm, there's a higher chance for lymph node metastasis, so lymphadenectomy may be done. For lesions greater than 2 cm, or if there's a positive lymph nodes, then you have to do a Whipple's procedure with regional lymphadenectomy if the lesion is at the head, or for distally located lesions, you have to do a distal pancreatectomy with splenectomy and regional lymphadenectomy. Then, for patients with advanced disease or metastatic PNET of in grade one or with grade one or two differentiation. If even if there's presence of metastasis, if complete resection is possible, then it is advisable to resect the metastasis and the primary tumor. Then non-curative debulking may be considered in select cases if the patient is symptomatic. Here, these are just the treatment options for patients who continue to progress, whose disease continues to progress despite earlier management. So lastly, we have the PDAC, pancreatic ductal adenocarcinoma. So the lesion is usually located at the head or onset process, and there's a KRAS mutation in 90%. For the workup, this includes a pancreatic protocol CT, or MRI can also be used if it's a high quality MRI. So the lesion appears as a hypoattenuating solid mass in the pancreatic and portal venous spaces. Additional workups needed include chest and pelvic CT scan and also liver function tests and baseline CA19-9 after adequate biliary drainage. So these are just the specifications of a pancreatic protocol CT scan. So this usually has thin cuts, less than 3 millimeters. You can give oral contrast, a neutral oral contrast, such as water. And there's a pancreatic parenchymal phase and the portal venous phase. Then for the CA19-9, you should note that this may be elevated due to biliary obstruction or infection, even in benign cases. That's why it was specified to get a baseline CA19-9 after adequate biliary drainage. Then another thing to note is that in Lewis antigen negative individuals, which is in around 10%, the CA19-9 does not elevate. Next, for the workup, for tissue biopsies, this is actually not required prior to surgical resection, but it's usually done if the patient needs chemotherapy. So EUS guided needle biopsy is preferred, but if there are suspicious liver lesions, then CT or ultrasound guided biopsy may be done for the liver lesions. The preferred biopsy target is the lesion that will provide the highest stage, such as the metastatic lesions. For patients with metastatic pancreatic ductal adenocarcinoma, there should be enough tissue specimen for next generation sequencing or molecular analysis. For biliary drainage, this is also not routinely done prior to planned surgery, but this would be needed if the patient is in cholangitis or has fever, has severe pruritus, or if surgery is being delayed. And of course, if the patient would need chemotherapy, then of course the patient would need a normal bilirubin level, hence the patient would need biliary drainage. It is preferred that metallic stents are used over plastic stents, and endoscopically placed biliary stents are preferred. But if it's not possible, then second line options include PTBD and EUS guided biliary drainage. So it's better to use stents, but if the predicted survival of the patient is less than 3 months, then plastic biliary stents can also be used. So we now go to the assessment of the resectability. This is usually included in the exam. So for resectable tumors, these are tumors with no arterial tumor contact or with with tumor contact with the vein but less than 180 degrees and without vein contour irregularity. For borderline resectable tumors, these include those with arterial contact less than 180 degrees, or those with venous contact more than 180 degrees, or venous contact less than 180 degrees but with contour irregularity. Then for locally advanced, or what we used to call unresectable, these are tumors with arterial contact of more than 180 degrees and unreconstructable SMV or portal vein tumor involvement or occlusion. So for resectable disease, if there's absence of high-risk features, then you can proceed with doing the surgery. As mentioned earlier, biopsy is not needed prior to doing surgical resection if the lesion is resectable. This is because it is not easy to get a proof of malignancy for PDAC since it is not a very cellular lesion and contains significant fibrous tissue. So sometimes some patients would need multiple biopsies before we can prove that the lesion is actually malignant. For patients with high-risk features, it's better to give neoadjuvant therapy first. So this includes patients with indeterminate imaging findings, with markedly elevated CA19-9, large primary tumors, large regional lymph nodes, excessive weight loss, and extreme pain. So for this slide, this is what do you do if intra-op you realize that the lesion is actually unresectable. So all this slide says is to consider doing the bypass only if clinically indicated, meaning gastric and biliary bypass or a double bypass is not routinely done in all patients. So the bypass is only done if the patient needs it. So for borderline resectable, the patient would need neoadjuvant therapy. So this includes doing a biopsy, and also if the patient is jaundiced, doing the biliary, referring the patient for biliary drainage in preparation for chemotherapy. For locally advanced disease, of course, the patient would need a biopsy, and as much as possible, molecular profiling of the tumor should be done if the patient can afford it. And if the patient is jaundiced, to refer the patient for biliary drainage in preparation for chemotherapy. So if the patient has a good or intermediate performance status, the patient can undergo chemo with or without radiation therapy. But if the patient has poor performance status, then other options include palliative therapy and best supportive care, or single agent chemotherapy or palliative radiation therapy. So for neoadjuvant therapy, this is given for patients with borderline resectable or with patients lesions that are resectable but with high risk features, and the first line therapy for neoadjuvant is FOLFIRINOX or modified FOLFIRINOX. For adjuvant, the first line is modified FOLFIRINOX or gemcitabine plus capecitabine. This slide just shows the other options for systemic therapy. So depending on the performance status of the patient can receive different regimens. As mentioned earlier, those with good performance status preferably should be given FOLFIRINOX or modified FOLFIRINOX. This slide just shows the the AJCC staging of pancreatic ductal adenic carcinoma. So I don't think you have to memorize this. But of note, according to AJCC 8, you need to get at least 12 lymph nodes. Then for the surveillance, for the first 2 years, we do history PE, CA19-9, and CT scans every 3 to 6 months. Then history and PE thereafter every 6 to 12 months. So that's it for the pancreas. I just have some very few slides for the spleen. So for the anatomy, the spleen is suspended by the following ligaments: the splenocolic, gastrosplenic, spheno-splenic, and the splenorenal ligament. And these ligaments are avascular except for the gastrosplenic ligament, which contains the short gastric vessels. And for the blood supply, it is supplied by the splenic artery and short gastric arteries and drained by the splenic vein and short gastric veins. These are the indications for splenectomy. So you don't really have to memorize all of these, but more or less these include benign and malignant hematologic diseases, and the indications for splenectomy usually are due to failure of medical therapy, the need for recurrent transfusions, symptomatic splenomegaly, and cytopenia. These are additional indications for splenectomy. So for the procedure of splenectomy, one thing to note is to ligate the artery first before the vein. This allows for safer manipulation and also shrinkage of the spleen and autotransfusion of erythrocytes and platelets. Then when dissecting the splenic hilum, you have to avoid injuring the pancreatic tail, which lies in close proximity to the splenic hilum. Then for my last slide, I just want to show the needed vaccinations for patients who undergo splenectomy. So this is to avoid overwhelming post-splenectomy infection, which has an overall lifetime risk of less than 1% to 5%. So the patient would need vaccination for encapsulated organisms. So these include pneumococcal vaccine, meningococcal vaccine, and the Hib vaccine. These vaccines are given 2 weeks prior to elective surgery, or for emergency surgeries, these are given 2 weeks post-op. Then some international guidelines also include an annual influenza vaccine as part of the vaccinations for post-splenectomy patients. That's it for the pancreas and spleen lectures.
Okay, thank you very